You gotta click.
No, we're trying to speak.
I'm Al Brown, Al.
Say Harry in Pittsburgh. We got you.
Yep.
Yep.
Okay. So, start. Recording in progress. Please, we're gonna get started here and, gonna introduce the speaker and start us off today. I have a script here. I have to look up what my name is. Hold on. Good morning. My name is Fred. Oh, no, that's right. No. Sabia. Sabia. Yeah, that would be me. You can tell by my name tag. Oh, it's in my jacket. So, I'm sorry. I am my mother's son. I'm a goofball. So on behalf of the You're Not Alone ministry team, we want to personally thank everyone for taking time in your busy schedules to learn more about mental health and the family's role in support. Today, we will be learning about depression, including examples, diagnosis, and medical treatment of depression. But first, let's pray. Abba, Father, we thank you for loving us, for redeeming us, for giving us a hope, a future and a hope, not only for this life, but for the next. I offer up prayer for all those who suffer with the heavy cross of mental illness. Thank you for working through this ministry. Please continue to, according to your will, bring people to this ministry who need it, who can be helped by it, who may not be able to afford professional help. Not that we offer that, but at least we offer support groups and these seminars. And bless all those who care for people with mental illness. And please give them the gift of hope that they can have a better life here and in the next life. And we thank you and praise you in Jesus' name. And we pray for our speaker, Dr. Andy, today. Amen. This program, this is a disclaimer. This program is not intended to provide guidance or direction in seeking medical assistance, direction, or medications. Referrals and medical assistance should only be sought from your individual physician or component experts. I'm sorry. Page 2.
It's on the backside. The other side, Fred.
Okay. The other side of the first page?
Yes. There you go.
Okay, at this time, I would like to introduce to you my dear friend, Dr. Andrew White. Dr. White, or as he's sometimes called by his friends, Dr. Andy, is a family physician who has recently retired. He has a special interest in mental health care, especially depression. Dr. White has personally experienced recurrent depression in his own life. He's the author of the book, Healing a Broken Mind, with a sample copy at the rear resource table. And if you want to get a copy, I would soon pay for it online.
You can get it on Amazon.
On Amazon.com. Dr. Andrew White, Healing a Broken Mind. And I and probably several others in this room can attest that it is an excellent book.
Excellent.
Please welcome Dr. White.
All right. I don't feel comfortable using a microphone, so I'll talk loud. I would recommend if you're sitting in the back to come as close as you feel comfortable. This is the first of two parts of a presentation. The first part is psychiatric, psychological perspectives. And the second part is perspectives from Christian faith. I have so much to share in this lecture that we may have to send some of it over into the next one. We'll just see how fast things go. It will be a packed lecture. I will have time for some question and answers after the second part of the lecture. And I'll be available up front for one-on-one conversations until 12:30. The lifetime prevalence, that is to say, what's occurring now in the US of an anxiety disorder is 31%. Wow. Anxiety disorders in the US within the last year are 19%. The percentage of Mexicans living in Mexico with an anxiety disorder in the last year is 25% of the US. Now, this was a statistic before ICE had its effect on immigrants. If a Mexican moves to the US, the statistics change to that of the US, a fourfold increase. Some people experience anxiety only under severe stress. Some experience it even under minor stress, and most of us are in between. There are many different words for anxiety, including anxiety, worry, stress, nervousness, restlessness, fear, agitation, panic, terror, dread, horror, and being overwhelmed, and I'm sure there are more. Interestingly, there are many fewer words in English for peace.
Wow.
The one I think of most commonly used is calm, and there's a common word used by Jews and Christians for peace, which is shalom. That's the Hebrew. It can also refer to well-being and wholeness, which peace can bring. Which many people with anxiety disorders don't experience that well-being and wholeness. There are many different words for anxiety, and it indicates it is more complicated than peace. So its diagnosis in anxiety disorders is more complicated. A little anxiety is often helpful. A little anxiety motivates us to prepare for the future challenges we may encounter in the near or distant future. A little anxiety can help us concentrate, but too much anxiety interferes with concentration.
Yeah.
If anxiety interferes with completing your present activities or attaining your life goals, it is counterproductive. When does anxiety become an anxiety disorder? It includes the following: exaggerated intensity of symptoms, persistence of symptoms when the anxiety-producing thought or event resolves, interference of symptoms in daily thought life and activities, sudden onset of severe anxiety or panic disproportionate to the thought or situation, generalization in that focused anxiety expands to different unrelated situations other than the inciting incident. Catastrophic thinking by imagining the worst outcome of a situation, not the most likely. Avoidance of any thoughts or situations that cause anxiety, and loss of a sense of safety or feeling calm. The symptoms of an anxiety disorder include common complaints of those who are anxious are nervousness, worry, mental restlessness, stress, irritability, fear, and even fear of fear. Physical symptoms include uncomfortable muscle tension, fatigue, headaches, palpitations, sweating, shortness of breath, chest tightness, stomach aches, headache, insomnia, numbness and tingling of the arms or legs, tremulousness, and dizziness. So there's a whole host of physical symptoms associated with anxiety disorder. Approximately 50% of patients with gastrointestinal dyspepsia and irritable bowel syndrome have been diagnosed with an anxiety or depressive disorder. Approximately 25% of patients who present to the emergency room with chest pain are having a panic attack. Fear of present and future threats is the underlying trigger of most anxiety disorders. There is a screening test that I've handed out to you that is used for many anxiety disorders. It can be used, it not only does it screen for many different anxiety disorders, when there is generalized anxiety disorder, it can actually help you determine how severe it is. And the first two questions can be used as a very brief screen for all anxiety disorders. I'm going to go over this in detail. You can look at your sheet, or you can look at this. But I do want you to, I think this is something you all should take. And if you have a friend or family member that you're concerned about, this is a great thing that you can share with them.
Yeah.
So here is the screening tool. And by the way, if the screening tool is positive, you still do need a psychiatric interview to make sure that it's not a false positive screen. Over the last 2 weeks, how often have you been bothered by the following problems? Not at all. Several days, more than half the days, and nearly every day. The problems are feeling nervous, anxious, or on edge, not being able to stop or control worrying too much about different things, trouble relaxing, being so restless that it's hard to sit still, becoming easily annoyed or irritable, and feeling afraid as if something awful might happen. It's important for the healthcare provider to know how difficult these problems are. Not difficult at all, somewhat difficult, very difficult, or extremely difficult. So if you have many of these problems, and it's not difficult at all or only somewhat difficult, you may not need medication or counseling. And then you score, and you can 0 to 4 is minimal anxiety, 5 to 9 mild anxiety, 10 to 14 moderate anxiety, and 15 to 21 severe anxiety. Okay, what I'm going to be sharing next is very complicated, and I will try to do it in a way that you can understand. If you don't, It's not that you're not intelligent, because even I had difficulty putting into words
Oh, yeah.
the neurocircuitry and anxiety.
Hmm.
Every state of mind and spirit has a neurobiological equivalent that often can be addressed by medication, counseling, self-help, and spiritual disciplines. Involved are both chemical neurotransmitter actions and electrical neurocircuitry actions in the brain as they relate to the biological functioning of the human mind. Different areas of the brain interact through neurocircuitry. A common neurocircuitry pattern in anxiety is the interaction of the amygdala, the hippocampus, and the prefrontal cortex. This is an example of the neurocircuitry in the brain, how it interacts. Right down here, this almond-shaped structure is the amygdala. The amygdala is what is responsible for the immediate feeling of fear when confronted with a potential or actual threat. It's responsible for what's called the fight, flight, and freeze response. Then the circuitry not shown in this slide goes to this hippocampus. And the hippocampus has it stores emotional memories of the fear that occurred from the amygdala. It's a little bit slower, but what it helps do is if you're experiencing a form of fear that if you're experiencing a form of fear that in the past was just a potential threat, not a real threat, the hippocampus will quiet down the amygdala. Ultimately, the circuits go into the cortex, particularly what's called the frontal cortex. And that's where your brain uses reason to control your anxiety and fear. These are PET scans. PET scans light up the areas of the brain that are active. The one on the left is someone without an anxiety disorder, and the one on the right is with someone who has a panic disorder. And these changes, different changes occur in all the different anxiety disorders. That all of them have a different PET scan than the normal control. Self-helps. This is going to be controversial, but this is my opinion based on research. There are no known diets that clearly are shown by research to help with mental health problems, except for the possible exception of taking in too much caffeine. People with a normal American diet do not need vitamins. They do not help, at least in the small research studies that were done. There are some supplements that may be helpful, and I would encourage you to go online. You can go to an AI place like ChatGPT and see which ones have some evidence for helpfulness. Some of them also have side effects, and some of them can interfere with the work of other medications. So be cautious. If they are safe and they're helping you, that's fine, of course. Exercise has definitely been shown to be helpful in mental illnesses, including anxiety disorders. We know what keeps your body healthy. 30 to 45 minutes, 5 times a week is enough to significantly help your physical body. And it probably also helps, it does help with your mental health. But in the case of using it for your mental health, I recommend you exercise every day. And don't miss one. And then finally, sleep is really important. Even people who don't have an anxiety disorder have problems the next day if they don't sleep well. And people with anxiety disorders are especially prone to have them worsen if they don't get good sleep. We'll talk more about that in a little bit. There's mindfulness is increasingly being shown to help anxiety. A common theme in most mindfulness approaches is drawing the person into the present moment, free from future fears and past ruminations. There are many different approaches to mindfulness. These are some of the most helpful, and they have been shown to be helpful in anxiety disorders. First is focused breathing. With focused breathing, you slowly breathe in and out using your diaphragm. And you do that repeatedly, each time focusing exclusively on your breathing. That brings you into the present moment. At first, you may find it difficult to concentrate with other anxiety-producing things coming to your mind while you're learning to do it. But eventually, you can get to the point where, like with me, if I'm anxious at bedtime, more than my mind is just going round and round. If I take 3 breaths, paying attention, everything calms down. So it's a great tool to use, even if you're in the presence of other people. The other, another form of mindfulness, what's called progressive muscle relaxation. And in that approach, you first contract your toes, then relax them, then your calves, then relax them, all the way up the body. And if you want to find even more about focused breathing and progressive muscle relaxation, again, you can go to an AI site. Tai Chi has been definitely shown to help with mental illness. In Tai Chi, you slowly assume different positions, and during those positions, you focus on where your body is, and again, it kind of brings into the present what's going on in your life now. Yoga is similar, but normally you just sit in what's called the lotus position, where you are sitting with your back straight and your knees crossed and your legs crossed. You can focus on your body position. It's also common to use meditation with it. The form of meditation is important if you're a Christian. I don't believe that saying the meaningless word over and over again, oh, is particularly helpful. But as a Christian, you may focus on something like peace or love. Thank you, Fred, and joy. Fred told me about these words.
Yeah.
And then you could do meditation alone. Among Christians, it's common to meditate on a verse or a passage. I also find it helpful to meditate on an insightful story that was helpful, or even a beautiful poem. So now we're getting briefly into the counseling aspect. In your relationship with a counselor, you'll always need to be confident that they empathize with you and that they're honest with you. Research has shown that counseling is less effective if you don't have that a part of the counselor's attributes. I think, and I don't think there's as much research study, I think that sharing your story with someone is helpful. If you keep your troubled story to yourself, it can be harmful. I think we're living in an age where story is not common. We live in an age where we can surf the internet and spend 2 or 3 seconds or 2 or 3 minutes on one thing and then move on to another. Yeah, it doesn't help developing meaningfulness in your life. And as Christians, our story can be a part of a bigger story, the Bible. Problem solving is just what it sounds like. It deals with problems that affect your life that cause anxiety. If you're stymied about a problem, you should consider getting the counseling of others, including friends, pastors, priests, and professional counselor. If you're making progress in your mental health, continue that counseling approach. But if not, your counselor may use a different approach and be successful with that. There's what's called the dialectical approach to problem solving. And it was originally a part of philosophy which Hegel had introduced. And the dialectical approach can be applied to problem solving counseling. This is the dialectical approach. Philosophically, it included the thesis, the antithesis, and the synthesis. The thesis in problem solving would be what the patient is saying. The antithesis might be what the counselor says. And then together, you come up with a problem solving plan. You can sometimes do this on your own. So the previous slide was also about cognitive behavioral therapy. This therapy has definitely been shown to be the most effective approach to anxiety compared to other approaches. The theory behind it is very simple and was first addressed scientifically by Aaron Beck about 50 years ago, who kept writing up till his death a few years ago The theory is simple. When you think and behave affects how you feel. If you are anxious, there are ways to change your thinking and your behavior that affects your feelings. And throughout the whole Bible, we are regularly challenged to change our thoughts and our behaviors. So I think it's very compatible with the Christian faith. I would say that's probably opposed to something like psychoanalysis that Freud came up with. It wasn't very effective, and it took weekly visits for a year or more. CBT can sometimes be as short as 3 sessions and usually doesn't go beyond 12 sessions. There are exceptions to this. PTSD often requires prolonged CBT. One way to address frequent untruthful negative thoughts is by what I call weighing the evidence. Untruthful negative thoughts can be related to a single traumatic event or many lesser traumatic events together. CBT teaches that you may have automatic negative thoughts, which are called ants, that occur over and over again when you experience the same situation. And these ants can contribute to untruthful negative feelings. This is a diagram of weighing the evidence, and I'll give you an example when we get to generalized anxiety disorder. But you start either on your own or with the help of a counselor. You come up with an untruthful negative thought, particularly an ant, an automatic one. And you list the evidence for that thought and the evidence against it. And when you look at both sides of the column, the patient will usually see that the evidence against the thought is more than the evidence for the thought. We will address exposure therapy again with an example when we look at social anxiety disorder. In exposure therapy, the patient by himself or with the help of a counselor comes up with the different situations that are threatening. And then they rate the degree of threat. And you gradually over time expose the patient to more and more threatening situations. You even often start with just imagining the situation. If you have a patient who has different ratings, you start with the lowest ratings and work up to the most difficult problems. Treatment recommendations often differ from those healthcare professionals who prescribe medicines and those who don't. Sometimes prescribing healthcare providers minimize counseling or don't even mention it at all. Sometimes counselors who do not prescribe medicines will emphasize the side effects of medicines. And you'll come to see shortly that the side effects are either mild and often are often cleared up spontaneously over a few weeks, or at worst, you stop the medicine. I'm happy to say that during my professional career, I got to know Fred. And Fred and I did not have problems with each. I could be sure if I referred someone to Fred, he would not minimize medication, and he often sent me patients who he was counseling, who he thought medicines would also help. And like I say, serious side effects from SSRIs and the large majority of other medicines are extremely rare and are reversible. SSRIs are the most commonly used medication for anxiety disorders. Again, you'll have to concentrate hard, but I'll try to make a difficult idea understandable. Selective serotonin reuptake inhibitors, SSRIs, are medicines used in the treatment of anxiety disorder, and they work by partially inhibiting the reuptake of serotonin in the synaptic cleft of the sending neuron. This increases the overall number of serotonin neurotransmitters in the synaptic cleft, which attach to the serotonin receptors of the receiving neuron. Serotonin receptors in the receiving neuron are not the only receptors that SSRIs affect, and their influence varies. Because of these other receptors that are affected and are different in each SSRI, often when one SSRI doesn't work, another will. And SSRIs are not only helpful with anxiety disorders, but also depressive disorders. And one statistic that jumps out at me is the one where 70% of people with depressive disorders have anxiety disorders. In my practice, it was 90%. All right, here we'll go through it. Up on the upper left, you see the cell body, and it has these tree-like branches. When stimulated by a sending nerve, those dendrites cause the cell body to send an electrical signal down the axon into the terminal, terminal. Oh, I can't remember what it's called. Axon terminal, yeah. That also looks like a tree with little apples on the end. When these terminals stimulate the dendrites that we talked about before, when the electrical impulse reaches the axon terminal, vesicles that have chemical neurotransmitters are released into the synaptic cleft. And in the synaptic cleft, these chemical neurotransmitters stimulate receptors, and as soon as they stimulate the receptor, they're released back into the synaptic cleft. The way reuptake inhibitors work is they partially prevent the reuptake of these neurotransmitters. So more neurotransmitters are in the synaptic cleft to reattach to receptors. There's your scientific talk for today. Yes, SSRIs do have side effects. I would say ahead of time, most people don't have any. The common short-term side effects are mild nausea and diarrhea, mild increase or mild in anxiety or mild sedation. And I would point out it's very important for the healthcare provider to tell the person with an anxiety disorder that they temporarily may be a little more anxious, but then they'll become less anxious. It can cause mild insomnia, mild dizziness, headaches, and sweating. These side effects resolve when the SSRI is discontinued. But I would recommend reducing the dose if the patient cannot even put up with these short-term side effects. And I call them short-term because within a few weeks they disappear. There are some long-term side effects of SSRIs. And again, these all resolve if the medication is stopped. They include sexual side effects, especially erectile dysfunction in men and anorgasmia in women. It can cause apathy, blunting of the emotions, weight gain, but very important, a lot of people with mental health problems who we recommend medications to are afraid the medicines are going to change their personality. Just the opposite. Most of those with an anxiety disorder who take medicine actually say they feel more like their old self. And like I said, all these side effects resolve with cessation of the medication. And once again, most of the time, these long-term side effects don't occur at all. There is definitely a severe side effect that's extremely rare called serotonin syndrome. And it is important that these people are in the ICU. I say extremely rare because I have never seen a patient with serotonin syndrome. And I asked a psychologist and a psychiatrist who were in their midlife, and they both said they had never seen serotonin syndrome except in someone who intentionally took a very large overdose.
Oh, wow.
Some of you may be on SSRIs. These are the common ones. Fluoxetine, Prozac, paroxetine, Paxil, sertraline, Zoloft, citalopram, Celexa, escitalopram, Lexapro, and all are inexpensive. There are two unique SSRIs. They not only work by decreasing the reuptake, but they also have a direct effect on the receptor itself. By the way, when I'm talking with patients about these neurons and the synaptic cleft, will point out that it's your very own chemical neurotransmitters that are affecting the anxiety. It's unlike something like Valium that directly affects the receptors, and I'll talk more about that later. They're also called serotonin norepinephrine reuptake inhibitors, and they're often a second choice if either the first or second SSRI is not effective. SSRIs can sometimes cause the short-term side effects and long-term side effects of SSRIs, and they can also cause rapid heart rate and high blood pressure, which disappear if the SNRI is discontinued. Both the rapid heart rate and the high blood pressure are not life-threatening, so they should be stopped if they're not helping. The common NRIs are venlafaxine, Effexor, desvenlafaxine, Pristiq, and duloxetine, Cymbalta. They're a little more expensive than SSRIs, but not by much. Buspirone is a unique drug, and we're not sure exactly how it works in relieving anxiety. In my practice, it has only reduced anxiety in 15 to 25% of people with anxiety disorders. And even when it works, it often doesn't work that well. But it is very safe with virtually no side effects, and it is not addictive. And by the way, SSRIs and NRIs are not addictive. I often use it before trying a benzodiazepine. Hydroxyzine or Vistaril is a sedating antihistamine and is available over the counter. It sometimes causes drowsiness, but it is very safe and non-addictive. And once again, it only works about 15 to 25% of the time in my practice. Mirtazapine is also a unique medicine, is that it's most often used for depressive disorders. It is a second or third choice for anxiety disorders. You should always at least try an SSRI before trying this. Its side effects are sedation and increased appetite, which are common, but it's ideal for anxiety disorders when the anxious person has insomnia and a decreased appetite. Once again, it's very safe and non-addictive. Pregabalin, Lyrica, is a medicine that is primarily prescribed for pain coming from nerves, but it sometimes also helps with anxiety. It too has few side effects and is not addictive. We rarely use tricyclic antidepressants and MAO inhibitors, but if everything else has been used and has not been effective, it's worth using. The problem is they have many mild to moderate side effects, which fortunately resolve with discontinuation. Rarely there are severe effects with high doses, so the benefits and harms of the medicine need to be carefully balanced and closely monitored. It should not be used if there are suicidal thoughts, because an overdose may be lethal. I've never heard of a lethal overdose in serotonin syndrome, but I have known a number of people that successfully committed suicide with a tricyclic. Wow. But in the right patient, these medicines can be helpful when all else fails. Benzodiazepines are very effective. They act directly on the GABA A receptors in the brain. Like I said, they are not reuptake inhibitors. Benzodiazepine medicines are the most helpful anxiety relieving medicines, and they often help with first dose, whereas other medicines like SSRIs and SNRIs can take several weeks to have an effect. Unfortunately, they are sometimes addictive and sometimes induce tolerance. Apart from severe acute stress disorder, they are often the treatment of last resort. Some patients on benzodiazepines develop tolerance to the drug, requiring increasing doses of the drug to have the same effect. People on benzodiazepines who develop too much tolerance may need to be weaned off the drug because they increasingly become ineffective. But this does not happen all the time. And benzodiazepines can also become addictive. But again, this does not occur most of the time. Some patients will exhibit addictive behaviors like buying it off the street or calling in for refills before the next prescription is due. Addictive behaviors can be managed by strict control of the prescription or weaning the patient off the medicine. And caution should be used in patients with other addictive disorders. That being said, and by the way, benzodiazepines work with the first dose. That's amazing. I do disagree with the majority of primary care providers and many psychiatrists who I think underprescribe benzodiazepines. In the past, they were prescribed too frequently. Decades ago, Valium was often called mother's little helper. Now, I believe they're prescribed too infrequently, especially in treatment-resistant severe anxiety disorders. Treatment resistance means that several SSRIs, SNRIs, and other psychopharmacological medications and counseling have been tried unsuccessfully. I have a number of patients that I use many different medicines, and a single small dose of this medicine at bedtime transformed their lives.
Wow.
The common benzodiazepines are diazepam, Valium, lorazepam, Ativan, clonazepam, Klonopin, alprazolam, Xanax, and none of them are very expensive. There are the so-called Z drugs for insomnia.
I know you've been going about an hour. I don't know where you are in your presentation, but if you tell us where
I'm
you want to
gonna
break.
stop after this.
Okay,
Yeah.
All right.
And then,
just make sure.
so there are the so-called Z drugs used for insomnia. They are a group of non-benzodiazepine prescription medicines, but they too can develop tolerance for addiction. So they should mainly be used short term. That being said, I find that many people who take it daily for severe insomnia, and by the way, they too should get CBT, because that can help. But even some who take it every day do not develop tolerance or addiction. So those with severe chronic insomnia may need help. Again, there are many healthcare providers who will not prescribe these medicines. The side effects include daytime sedation, dizziness, and falls, especially in the elderly, due to decreased coordination and rarely abnormal sleep behaviors like sleepwalking. They're called Z drugs because their names include the letter Z. Sulfidin, Ambien, it's the cheapest. Zolpidem, Sonata, and Ezobicolone, Lunesta. I always call it Lunesta because I can't pronounce that generic version. All right, let's stop here for 10 full minutes. I will leave, be open for question and answer at the end of my next section. And please be back here by 12 minutes after 11.
Okay.
Start for you can find a lot of helps for sleep hygiene on AI. It includes things like using your bed only for sleep and sexual activity. It can include not exercising just before you go to sleep. Exercising in the morning it will work, includes not taking naps. There are a number of different ones, and I recommend if you have problems with insomnia, you do that. But many patients who have, yes,
Blue lights is another thing before bedtime, like the computer and cell phone.
Yeah.
and
Oh.
TV before bed, they recommend using the blue blocker light.
yeah, exactly. Patients who have used sleep hygiene and have not gotten enough relief, and who are not prone to tolerance or addiction are often shortchanged in terms of getting medication help for insomnia. Once again, many primary care physicians and many psychiatrists don't believe in medicines for that. And of course, these people have never suffered from insomnia themselves. And it definitely makes a difference in controlling anxiety disorders. If your anxiety disorder is out of control, good night's sleep can go a long ways. If there's not enough time in a regular office visit to address insomnia, schedule a separate appointment with your healthcare provider. But if your healthcare provider, your PCP, doesn't help you with one of the Z-drugs or benzodiazepines, you need a new healthcare provider. That simple.
Yep.
But sometimes, often a primary care doctor, especially with a geriatric patient, will have so many chronic illnesses to address that they don't have time to address insomnia. It's not that they ignore it, they just don't have time.
And Dr. Andy?
Helping a patient over, yes.
Question.
I've been thinking, and I want to ask if you agree with this in your clinical experience and so on. It seems to me modern, at least American, I don't know about other countries, there's so much stress that we have, in my opinion, 3 epidemics going on simultaneously. You have the epidemic of mental illness, which is on the rise among different age groups, especially anxiety. You have the epidemic of loneliness. I've given a talk on that. And then you have the epidemic of insomnia. So many of my patients don't sleep well. And that prolongs and worsens even mild anxiety. And then
And PCPs and psychiatrists can really help them, but some of them don't.
that's
Sadly.
yeah.
Okay, now we're getting to some specific anxiety disorders. In the DSM-5-TR Manual of Mental Health Disorders, expert psychiatrists have come together to identify the criteria needed to diagnose different anxiety disorders. And every few years they update it. These anxiety disorders include generalized anxiety disorder, social anxiety disorder, panic disorder, agoraphobia, illness anxiety disorder, somatoform anxiety disorder, and specific phobias, all of which we'll briefly address. The DSM-5-TR reserves for other categories their own category, obsessive compulsive disorder and post-traumatic stress disorder, even though anxiety is a big part of these mental illnesses. The first is adjustment disorder with anxiety. It differs from a normal response to significant change in one's life. There's often nervousness, worry, or jitteriness, and many common changes in life can cause adjustment disorder with anxiety. For example, conflict in an interpersonal relationship, death of a loved one, separation and divorce, job loss, a serious medical illness, beginning school, leaving home for college, getting married, becoming a parent, having the lost child leave home, retirement, or failing to achieve the educational or occupational goals. Many people with adjustment disorder with anxiety can improve with personal reflection and or sharing with a trusted friend. When the symptoms are severe or are not steadily improving, counselor is often helpful, including individual or group therapy. An example of group therapy is hospice for those who have grief-related anxiety.
Oh.
Medications are rarely indicated. Once in my life, I had an adjustment disorder. I'll tell you a little story. When I was 3 years old, living in Panama, a neighbor woman gave me a dime because I saw that all her kids had something from the dime store. She said, when your mother comes back, you can go to the dime store with this dime. Well, I didn't wait for my mother. At 3, I put on my father's surgical cap and his mask. And I went to the dime store alone. And when I got into the dime store, the shopkeeper said, "Who are you?" I said, "Dr. White." All my life, I've either wanted to be a doctor or was a doctor. So when I had to retire because of hearing problems 2 years ago, I suffered anxiety for about 6 months. I just did not know what would make life meaningful without practicing medicine.
Yep.
But since that time, I've found many things. My life is very full, and it includes joining You're Not Alone ministry and writing a book that will come out in the fall called Facing Your Fear and Anxiety, Perspectives from Christian Faith, Psychiatry, and Psychology.
Wow.
And you don't need to buy this book if you come next time too, because a lot of it is in here.
Excellent.
There's also something called acute stress disorder. It is defined by severe anxiety due to a threatened or real exposure to a severe adverse event or trauma, but it is short-lived. The frequency of ASD is unknown because most people don't consult a professional. But those who do have a suicide risk 10 times that normal people. With acute stress disorder, the symptoms resolve when the stressor has passed. And if symptoms have not improved in 1 month, the problem may be post-traumatic stress disorder. The symptoms of ASD include intrusive symptoms. For example, sudden severe memory of the traumatic event or frequent nightmares about the traumatic event. There can be dissociative symptoms. For example, the world feels unreal to you, or you feel you're outside your body looking at yourself.
Wow.
There's also hyperarousal, where people often have a startle reflex. If someone comes behind you and pats you on the shoulder, you go like this. And also, it involves avoidance.
Yeah.
There is, the avoidance includes, avoiding anything else that might provoke the symptoms of ASD.
Wow.
Common example would be a major car accident, or even someone witnessing a violent assault on someone.
Wow.
There's something called trauma-focused CBT that is very helpful. Exposure therapy works. We're going to give an example later. And short-term benzodiazepines are sometimes used when the anxiety is severe. And it's always important for the healthcare provider to tell the patient that this is a short-term solution. We will not continue this for long. And SSRIs and SNRIs and the other medicines, many of the other medicines take too long to be effective. It's over within a month. That's about the time when when they start to be effective. It's a different thing when it turns into PTSD, which we'll talk about. Generalized anxiety disorder, GAD, is very common. The report is, it is reported to be 3% of the population. Now, in my practice, it was much more common. Not these people would present with medical illnesses that, or thinking they had a medical illness, but really had this problem. Only 1/3 of those with GAD seek professional help. The main symptoms of GAD are persistent, excessive, uncontrollable anxiety about many different things in one's life. And there are often physical symptoms, including disrupted sleep, fatigue, impaired concentration, irritability, muscle tension, and restlessness. There's anticipation of many different situations. This anticipation occurs in many different situations, not just one. These patients often worry about many future possibilities, many of them unlikely to happen. Most of those affected by GAD know their anxiety is unwarranted, and yet they have it.
Wow.
Many people with GAD say that as long as they can remember, they have been anxious. There's a definite genetic component. If you have a family member with GAD, you're more likely to get it yourself. And there are often temperaments that start very young in life, where the infant or child shows signs of nervousness or excessive shyness. They'll be the person that they'll be the child that is brought into nursery school by his mother, who has a lot of separation anxiety, may cry out for help. If they stay in the nursery school, they may be the one that's standing next to the wall while everybody else is participating. And clinical disorders like anxiety and depression often erupt when a genetically susceptible patient. Clinical disorders like anxiety and depression often erupt when a genetic susceptibility to psychiatric disease combines with life stressors that are overwhelming the individual ability to cope. And SSRIs and SNRIs are the most commonly used medicines for GAD, although Buspar, hydroxyzine, some of the others can also be used. Long-term benzodiazepines are often helpful when anxiety is severe and all other treatments fail. including trials of several different medicines and also counseling. Here's weighing the evidence, an example. The untruthful negative thought is my children are in danger when they go to school. The evidence for the thought, there have been school shootings. The evidence against the thought, the school has a security plan. For the thought, school shootings have been increasing. Against the thought, school shootings are still relatively rare. For the thought, I want to keep my children at home. Against the thought, for social and academic reasons, my children should go to school. And who will watch my children when they're not there? Of course, teachers will, but God also watches over us. And then you come up with a truthful, positive thought, often together with your counselor. My children are well protected when they go to school. I entrust them to God. Panic disorder is currently occurring in 3% of U.S. citizens. Panic attack is the result of a sudden, usually spontaneous overactivation of the sympathetic nervous system, or a sudden stimulation of the amygdala. Panic attack includes extreme fear of having a heart attack, fear of dying, or fear of going crazy. To mention a few, the person feels completely out of control. Other symptoms always include physical symptoms like palpitations, sweating, trembling, shortness of breath, sensations of choking, chest pain, nausea, dizziness, chills, numbness and tingling, and derealization, feelings of unreality or depersonalization, feelings of being detached from oneself. Fortunately, the symptoms abate in 20 to 30 minutes. The author of a book I read in preparation for this talk said he was more frightened by panic attacks than when a tornado hit his home, causing 2 large trees to crash into his home, destroying several rooms and escaping with his life. The symptoms are so frightening that there often is intense anticipatory anxiety of a panic attack occurring again. Sometimes the panic attacks become associated with a particular situation. For example, if it happened in a grocery store, you may not go into a grocery store again. The patient with panic disorder will often actively avoid at all costs the particular situation or place where the panic attack occurred. And unfortunately, panic attacks also occur out of the blue. Because the symptoms are so intense, the person may repeatedly go to the emergency room where the workup for a medical cause is negative. And it is not uncommon that people with panic disorder develop substance abuse problems to alleviate their anxiety. If a person presents with a classic panic attack, there really isn't any need for a thorough medical evaluation. By that, I mean there would be many different symptoms that can't all be associated with a specific problem, medical problem. The SSRIs and SNRIs are the medications of first choice, and occasionally benzodiazepines can use, for example, however, they do not help panic attack itself. What they help is if a person has severe anticipatory anxiety after a panic attack, they help. but long-term, you would rarely use a benzodiazepine. Exposure therapy to the various situations that cause panic attacks can be helpful. And when you're actually dealing with a panic attack, what you need to do is do what's called leaning into the panic attack. That means you, in your mind, accept that you're having a panic attack, not some life-threatening problem,
Right.
and that it will resolve in 20 to 30 minutes. And you just hang in there during that time. 1/3 of patients with panic disorder develop agoraphobia because of the anticipatory fear induced by potential panic attacks. These people avoid many places where their fear is increased. Over time, they avoid more and more places or situations. The world becomes very small. Some won't even come out of their house. This leads to social isolation, which is so harmful to all mental illnesses. Again, the SSRIs or SNRIs are helpful. Rarely benzodiazepines can be used long-term. And I should point out that agoraphobia can develop independent of panic disorder. Counseling in agoraphobia can be very helpful, especially exposure therapy. 7% people in the US currently suffer from social anxiety disorder. That actually is probably a low figure because many people do not go for help when they have the disorder, and it often takes many years before it's diagnosed. Social anxiety disorder most often occurs in both the anticipation of social events or during the social events, whether in large groups or one-on-ones. These events may include attending school and meetings, especially if giving a presentation.
Yep.
The most common features of social anxiety disorder are fear of negative evaluations, heightened self-focus, especially focusing on your social performance, and extensive avoidance of groups of people as much as possible. There is a single question that is a foot screen for social anxiety disorder. Do you find yourself avoiding social activities more than usual? And if that answer is yes, it should be evaluated further by a counselor or a healthcare professional. Many of us without social anxiety disorder feel somewhat anxious in having to talk to others in social situations, especially new ones. But the anxiety is much more intense with social anxiety disorder. And among those who are diagnosed with social anxiety disorder, there's a 23 times higher incidence of suicide.
Wow.
There's a genetic component to social anxiety disorder. Again, there's a family member who has it, you're more likely to get it. The medications include SSRIs, SNRIs, propranolol. That's a drug, a heart medicine. It slows down the heart rate to prevent palpitations, and it also helps control trembling. So many people who are making presentations will take propranolol before they presentation, but some people don't respond. And in that case, it is legitimate for the patient to take a benzodiazepine before the exposure, unless the exposure happens every day, in which case you don't want to be on that law. There are 5 types of unhelpful beliefs in social anxiety disorder. These are the untruthful, negative beliefs. I believe that people don't find me interesting. In social situations, people are looking for my weakness. I cannot tolerate disapproval. I need to come across as competent. I often feel anxious in the presence of others. In cognitive therapy, behavioral therapy, including exposure therapy, helps anxiety disorder, social anxiety disorder. Here's an example of an exposure therapy diagram. To the left is the situation: going to a grocery store, going to a party, calling a friend, sending an email, meeting with a friend or for coffee, and each is rated on the degree of threat. And in this case, you would start with sending an email.
Right.
And when you'd conquer that, calling a friend, and then
Right,
right up,
right,
and then typically there'll be more than just 5. About 1.2% of the population in the US currently has obsessive compulsive disorder. In OCD, there are uncontrollable intrusive thoughts, ideas, images, or urges. These obsessions can include fear of contamination by germs, fear of deliberately or inadvertently harming oneself or others, even though this never happens. Now, if a schizophrenic has fear of inadvertently harming himself or others, that has to be taken pretty seriously. There's also repetitive fear of physical symptoms, which the person thinks represents some serious medical problem. There are intrusive thoughts about things that are considered taboo, like stress. There can be an overwhelming fixation on symmetry, like the arrangement of clothes in a drawer closet. They worry about their obsession, even though they know it's unwarranted. And hoarding is common. Piling up newspapers. Scrupulosity is an interesting one. It's where you have a religious obsession. One example I had was a woman who every 10 or 15 minutes would recite the Lord's Prayer.
Wow.
I'm lucky if I do that every day. I should. These obsessions result in a strong urge to perform various compulsions, sometimes called rituals. There's repeated hand and body washing, sometimes to the point where the skin is rubbed off. The repeated checking, like whether the doors are locked or the strobe is left on. Arranging things in a strictly specific disorder. And mental acts like counting, repeating words or numbers, even praying over and over again the same thing. Failing to perform these compulsions results in marked anxiety, for which acting on the compulsion often gives partial but only temporary relief from the anxiety. And once again, people with OCD often know that these obsessions and compulsions are not helpful, not wanted. Pharmacologic treatment is usually with an SSRI, and it needs to be used most of the time at the highest dose, and occasionally I'll even go higher than the recommended dose.
Wow.
CBT includes weaning off the compulsions. For example, if you wash your hands every 15 minutes, stretch it out to 20 minutes. 30 minutes, 45 minutes till you are finally weaned off, but there are many other secret things. Sometimes it's helpful that the counselor actually is with you when you're about to do something compulsive. Weaning off compulsions is very hard for an OCD patient to do due to the intense anxiety, and usually needs the support of a counselor. The longer these OCD symptoms persist, the harder it is to treat them. Finally, post-traumatic stress disorder. Post-traumatic stress disorder is present in 3.5% of people in the US. About 1/3 of people who experience severe traumatic events experience PTSD. To diagnose PTSD, there must be a major traumatic event or multiple moderate traumatic events occurring to oneself or witnessing. Some of us can endure the most severe traumatic events without developing PTSD. And some cannot endure even mild traumatic events. And of course, the classic PTSD is in veterans who have actually been in contact and witnessed a war or death. Fortunately, the VA has a very good system in dealing with PTSD. There are 5 areas of brain dysfunction that are found in PTSD. Intrusions like the sudden onset of vivid, distressing memories of the traumatic events, sometimes cause flashback, and frequent nightmares related to the traumatic event. There are often negative thoughts, including pessimism about the future, difficulty concentrating, sensing an inability to cope with life now, and reduced interest in current activities. Negative emotions include irritability and estrangement from friends and family. Insomnia is common. Hyperarousal, like an exaggerated startle reflex or surveying your surrounding for a potential threatening event. I have had a patient who, every time he entered a store, would look all around for potential threatening events and look where the exit was so that he could get out as fast as he could if the threat occurred, which was highly unlikely. And these people often use avoidance of previously distressing situations or places. And it should be noted that a common there's a common occurrence of avoidance in almost all mental health problems. And acting on the avoidance can make things much worse. PTS often robs you of experiencing the present moment. You're stuck in the past, ruminating, or stuck in the future, vividly anticipating the future, and can affect the present moment and that you're hypervigilant. PTS usually begins shortly after the traumatic event, but if the symptoms resolve within 1 month, it's called acute stress disorder. If the symptoms begin much later than the inciting event, it is called delayed onset PTSD. And PTSD is commonly associated with mood disorders like depression, anxiety disorders like generalized anxiety disorder, and personality disorders, especially borderline personality disorders. So if you're treating PTSD, you should also make sure to treat the associated problems. SNRIs and SNRIs are often helpful. Benzodiazepines are most of the time contraindicated. prazosin has not been proven in research studies to be effective in treating PTSD-related nightmares, but in my experience, it is often very effective. There are many different approaches to CBT that are helpful, but there's one especially helpful one that is not used often in other problems. And that's called eye movement desensitization and reprocessing, EMDR. And that the counselor has you hold your head still and follow his finger back and forth across the eye fields, which stimulates alternately different parts of the brain. And while he's or she is doing that, he counsels in a specific way. Rick tells me he has some patients with PCT that needed one treatment.
Wow. Mm-hmm.
I'm going to leave these last ones until the next lecture because I want time for questions and answers. Any questions? Yes.
Doc, you mentioned MAOs. What does that stand for?
Oh, it's called monoamoxidine inhibitors. The reason they're not used frequently is they frequently can cause severe reaction if you take certain medicines or if you eat certain things in your diet. But I've had patients who everything else failed and an MAO inhibitor worked. So, yes.
You did mention trazodone before.
Pardon?
You did mention trazodone as
Oh,
well.
trazodone, I love that medicine. It's very helpful in insomnia, particularly insomnia associated with a mental illness. And it often works at very low doses. At just 50 or 25 or 50 milligrams may help, but you can go as high as 300. So that I'm glad you mentioned that, and I'll include it in future talks.
Is that the purpose of the drug, just for insomnia?
Um,
Is the purpose of the drug just for insomnia?
It has a little bit effect on depression, but its main effect is on insomnia, and it has occasionally there'll be a little morning drowsiness, but usually there are no side effects, and it's definitely not addicting.
Yeah.
I usually also, if I have a patient with mental illness, that will often be the first thing I go to.
Yeah.
Yes.
You mentioned hydroxyzine or Vistarol as an over-the-counter for sleep.
Yes.
When I Googled that, it's only by prescription.
Hydroxyzine.
Hydroxyzine, Vistarol,
Yeah.
only by prescription.
It's only by,
Okay. I didn't know
Oh,
that.
yeah.
I normally have just recommended it to patients. And did you look up hydroxyzine or Vistarol?
Hydroxyzine.
Okay. Well, that would be a good thing to prescribe.
Okay, right. And the second question, you mentioned another drug. I didn't get the whole name. It began with Perg something. You said it was good for pain for nerves,
Yeah,
nerve pain,
that's pregabalin, also called Lyrica.
Lyrica. Okay.
Yes.
Is that, when you say nerve pain, are you talking about neuropathy?
Yes.
Really?
Yes, it's a great drug for neuropathy,
Wow.
but it sometimes, again, maybe 15 to 25% of the time will help with anxiety disorders.
Okay, so the name is,
And it is not addictive, and you don't develop.
what's the name of the drug?
Huh?
The name of the drug?
Lyrica.
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 Okay, I'm talking to my doctor about that.
Mark asked me a question that I want to answer. He asked me, why is it that reuptake inhibitors are best at these? Why inhibitors? Well, what happens normally, again, is the axon terminal releases the neurotransmitter. It briefly attaches to a receptor and then is scooped back up by the sending neuron.
Right.
That leaves more neurotransmitter to attach and then loosen, then reattach. So you get much more of a serotonin effect.
Right.
Um,
Because serotonin is a good enzyme. It's it's good for mood, sleep, digestion, and wound healing.
Yeah.
So
it's a good
you
drug.
want more of it available to the body.
Yeah.
So you want to inhibit the reuptake.
Yes,
What about amnesia associated with Ambien and C drugs?
oh, it's
Amnesia.
actually extremely rare. You may have had some bad episodes, but I honestly have never had a case of amnesia, and I have prescribed thousands of amnesia. But a lot of psychiatrists steer away from it, and will, because of that rare problem, or because of sleepwalking. And they will use the much more expensive Sonata or Lunesta, which have not been shown to ever cause amnesia. But I honestly, I used it all the time, and I never had a patient prescribe, have a problem, so, yes.
My experience, I was on Lyrica for my nerve pain and everything.
Pardon?
I was on Lyrica,
Uh-huh.
but my experience was bad because, I'm bipolar 1. So
Oh.
it enhanced my manic episode.
No.